Osmita, can you
Yes, sir,
start? Okay.
you can start the session, sir.
A very good morning, everyone. Today we have another webinar of the Cognitive Neurology subsection. As you know, we have started these webinars in this year, and every 2 months we are holding these webinars. In each webinar, one senior faculty usually delivers a lecture, and it is followed by a case presentation by residents mentored by one of the senior faculties. So today we are lucky to have one of our senior colleagues, Dr. Ramsekhar Menon, who is an expert in the field of cognitive neurology, as well as his works in the field of epilepsy, particularly in pediatric epilepsy, is well known to the epileptologist as well as to the neurologist of this country. He is the professor at Department of Neurology at Sri Chitra Tirunal Institute of Medical Science and Technology, Trivandrum. He has several laurels to his credit. He worked with the team of other cognitive neurologists in this country to develop the neurocognitive toolbox under the aegis of ICMR. He has worked extensively in the field of mild cognitive impairment, particularly in radiological features, the MRI features, and tried to find out the predictors who are subsequently getting converted into Alzheimer's disease and other dementias. So we are lucky to have Professor Menon with us, and he will be delivering a lecture in the field of his own passion, that is mild cognitive impairment. And I, first of all, invite Professor Menon to speak on this, and it will be followed by a case presentation by Sandeep from Hyderabad and his resident. So at the moment, we are going to have the presentation by Dr. Menon. I invite Professor Menon to deliver his lecture.
A very good Sunday morning to all of you, and thank you for giving me this opportunity, Professor Biswas and Fahim, on the Sunday. Let's see how we can get the audience interested, and I hope that we have them towards the end of this seminar session. I hope I'm audible to all of you.
Yes.
Okay. So what I'll try to do over the next 25-30 minutes is primarily tell you about the spectrum of this entity, which is referred to as mild cognitive impairment. So as all of you are aware, this is a very heterogeneous entity and of diverse etiologies and with variable trajectories. And what the focus of this talk would be primarily on trying to decipher the degenerative spectrum of mild cognitive impairment because of the emerging therapies which are appearing on the horizon, as well as with the focus in trying to identify certain treatable etiologies. And plus, when we come to the aspect of prognostication in these patients, it is very important that we realize the consequences of making a diagnosis of MCI due to a specific etiology. So basically, we'll briefly touch upon the concept of mild cognitive impairment without going too much into historical aspects. Then I will primarily take you through the neuropsychological diagnosis of the subtypes before going into the etiological spectrum. And we will end with a case-based approach, which will be taken forward always, obviously, in the next talk. So MCI as a concept. So you often have patients coming to your clinic who report difficulty in remembering names, difficulty in, recalling events, then, difficulty in often remembering the time and days of the date, as well as the next task that they are supposed to do. And most of them come with this concern whether they are developing a progressive cognitive decline, which can amount to degenerative dementia. So any subject who reports or often corroborated by the informant, if there is a report of cognitive decline in any domain, whether it is memory or non-memory domain. Obviously, most of us in our clinic, we will see patients who report memory problems, but there may be the patients who may report the non-memory domains also to be affected. But this has to be corroborated by an informant ideally, but not necessarily. So if the subject feels that there is a decline and that has affected his day-to-day activities, particularly in terms of employment as well as day-to-day functioning, then definitely they would come to you, and that you should give due weightage to that without relying too much on the informant. But definitely, if it is corroborated by a particular informant, it would add weightage to your diagnosis. But most importantly, although they may report, some complex activities may be involved, all their basic activities with regard to daily functioning would be unaffected. And only, sometimes in employment, they might have certain issues. Now, why this entity is important is primarily because of the fact that, this preceded by a specific complaint, that is subjective memory complaints, has also been found to have a slightly higher incidence of dementia risk in certain studies. So in this particular study, subjects who had only subjective complaints and who were neuropsychologically normal were followed up subsequently over the years for the risk of incident dementia. And what was found is that those subjects who had a history of subjective memory complaints were 6 times more likely to develop dementia as compared to somebody who had a non-memory complaint. So which means that you need to give due importance to the symptom. But obviously, to make the diagnosis of mild cognitive impairment, you require objective demonstration. And that is where the challenge comes as to whether you really want to do a detailed testing. But at the same time, you need to look for presence of comorbidities like uncontrolled diabetes, hypertension, sleep apnea, or prior history of head injury, which may be contributing to these symptoms and which may require or which may mandate longitudinal follow-up in these subjects. Obviously, the challenge for all of us when we encounter subjects with early cognitive disturbances, whether it is in the memory or non-memory domain, is trying to distinguish whether this is a profile of normal aging or dementia. So now, primarily, you had this entity of age-associated memory impairment as well as what is referred to as senile cognitive impairment previously is now considered to be a part of the normal physiological processes which accompany aging. So what happens during normal aging is that you have a state of tonic under-arousal where they tend to become more slow. That is, psychomotor slowing can happen. And that is how it is reflected in the various processes. And most commonly, this is reflected in terms of impaired attention, as well as retrieval deficits with regard to the memory. And the retrieval deficits meaning that they can have a fairly good cued recall with an impaired ability to, freely recall. So when they use cues, they tend to recall better. But typically, they have this typical aging pattern of intelligence, which is primarily characterized by the ability to rely on past experiences to generate information as well as to educate people around them. And that is often referred to as the classical aging pattern of intelligence, which is a very interesting concept in itself, but it is not something which we measure objectively. And often you would see that their language may be accompanied by certain pauses, and they may go on to a more elaborative descriptive phase of describing certain problems as well as their experiences when it comes to normal definition. And all these should be taken into consideration when you are testing the subject, because these are normal aspects when it comes to aging. But obviously, if the subject is having a cognitive decline, which is affecting the activities of daily living substantiated by a bystander, you would want to test the person further. So these were the original criteria which were formulated by the American Medical Association, primarily led by Professor Peterson, who is the pioneer with regard to recognition of this particular entity of mild cognitive impairment. And primarily, the focus is on subjective complaints along with objective impairment for aging. And this objective impairment should be not only corroborated by the bystander, but also in the form of neuropsychological testing. And the neuropsychological testing should encompass more than one domain. It should not be only the memory domain. You should always rely on the non-memory domain also. And then you should look at the activities of daily living, because these should be essentially normal to classify the subject as mild cognitive impairment. But we will see the limitations with regard to this particular approach. And with regard to NCI, you need to have certain diagnostic criteria with regard to what scores you need to use when you are diagnosing mild cognitive impairment. But roughly, what is often followed is that you can rely on either one test in one particular domain or 2 tests in a domain. And we will see what is the problem with the approach when it comes to diagnosis of this entity of mild cognitive impairment and what are the cutoff scores that you need to rely upon. Now, this is the clinical dementia rating scale, which is often used across studies, both in the clinical as well as in the research domain, with trying to understand what is the impact of mild cognitive impairment. As you can see, it relies on not only memory, but also looks at aspects such as orientation, judgment and problem solving, community affairs, home and hobbies, as well as personal care. But you can see that it does not give a lot of importance to, the actual occupational functioning or what is the occupational challenge which is encountered by the subject, as well as with regard to, social cognition, how the person is doing with regard to, social functioning as to with regard to motivation, judgment. Although once there is a severe impairment, it affects judgment and problem solving, and that is what is reflected in the clinical dementia rating scale as evident in that scoring section 2. But you can see that this may not be a true reflection of the actual impact of the cognitive deficit in the subject. And now we are moving from not only subjective and objective demonstration, but also trying to establish whether a subject at baseline with potentially a diagnosis of MCI has a biomarker which is positive. And in the modern era, most of the biomarkers seem to be focused on a degenerative entity such as Alzheimer's dementia. And as you can see, there is the amyloid tau as well as neurodegeneration framework, which I will be briefly touching upon later, which would help us to establish whether the subject has an intermediate or a high likelihood of MCI due to Alzheimer's disease. But most importantly, I want you to pay attention to the fact that, when you examine an etiology for MCI, you need to rule out treatable causes as well as other static causes such as vascular insult, traumatic brain injury, medical causes of cognitive decline such as hypothyroidism, obstructive sleep apnea, where possible. You should ensure that you're not treating or you're not assessing the subject in the phase of active depression, which can confound your neuropsychological testing before you decide whether the test scores are really relevant and whether these test scores can be relied upon. And I will show you the pitfalls with regard to establishing as to whether the test score is significantly impaired. Now, briefly touching upon the epidemiology of MCI, I'm not going into details of individual studies, but these are just what I have, put up in a book chapter recently. These are the incidence rates which have been found to be highly heterogeneous based upon the assessment protocol which has been followed. So if certain studies have used a global screening instrument such as MMSE or ACE or MOCA, they seem to have a higher incidence as well as prevalence rate in comparison to studies which have used a more detailed neuropsychological questionnaire or neuropsychological assessment. So you can see the heterogeneity of the incidence rates across the studies, and the prevalence estimates have also varied between 4.3 to 25%. But importantly, what are the rates of conversion to dementia? You can see the rates have varied between 6.6 to 37%, depending on whether the studies have been done in the hospital or at a community site. But roughly, this translates into an annualized risk of 5 to 10% per year. But importantly, up to 40% of MCI cases either do not convert to dementia or can revert to a cognitively normal state on follow-up. Ode to Professor S.K. Das, late Professor S.K. Das, and Professor Biswas was also part of this phenomenal study, which actually looked at the prevalence of MCI in the community. And this had tuned a prevalence of 15% in the Kolkata cohort, which were basically sampled by a process of systematic random sampling. And you can see that the amnestic as well as the multiple domain subtypes, which involve multiple cognitive domains, are reflected in this particular study. And after adjusting for age, education, and gender, amnestic subtype was more common in men, and the multi-domain subtype, which involved multiple domains, were common in women with advancement of age. And major risk factors which have been identified for MCI were hypertension and diabetes mellitus. Now, looking at the risk factors, I'm not going into details of this. As you can see, this slide is self-explanatory, and this is very much similar to the dementia risk profile. And the risk factors for conversion from MCI to dementia is what is reflected in the second column. That is, you have older age, lower education, ApoE4 status. Women seem to be at a higher risk, impaired baseline IADL and CDR scores, then presence of diabetes and hypertension, presence of subclinical depression, multi-domain MCI, as well as when you have a reliability of certain test scores at the baseline to predict the risk of conversion in MCI. Why it is important to establish this conversion risk? So one of the things is that you have certain protective factors, which you are very well aware of. So the study on the left basically looks at the protective effect of higher education with regard to mitigating the effect of a high tau burden. So what has been found is that using tau PET, in subjects who had a lower versus intermediate tau uptake, education was found to be significantly protective as compared to somebody who had a higher tau uptake. And this was done in 366 A beta positive individuals with MCI or early dementia. And also, we know that the Lancet 2020 review had recently come out with various protective life course factors which can be modified throughout the life course to bring about a 40% reduction in the cumulative risk of dementia over time in somebody who has an early life intervention, midlife versus late life intervention. And you can see that this is a sum of various factors which come into play. And obviously, the factors which cannot be modified are age, genetic risk, as well as family history of dementia, as all of you are aware. Now, with regard to the neuropsychological presentations of MCI, if the subject has a cognitive complaint, which may not be necessarily normal for the age, the subject is not demented, and essentially normal preserved functional activities with regard to social and occupational functioning, as well as day-to-day functioning, the first question you ask is the memory affected? And then if the memory is affected on your testing, you try to identify whether the subject has amnestic MCI, which may be either single domain, that is isolated memory domain, or involving other non-memory domains as well, which would become multi-domain. If, on the other hand, you have a subject who has an impairment in a non-memory domain, which may be in the executive domain, attention domain, the praxis domain, visuospatial domain, or language domain for that matter, and most importantly, not to forget the behavioral domain, then this could either be a non-amnestic MCI, and based on the neuropsychological test scores, you decide whether this is single domain or multi-domain. Now, how easy or how difficult is it to diagnose it by using certain baseline global cognitive screening tools such as MoCA, or for that matter, ACE? So our ICMR task force, which was led by Professor Aladi, and you can see that this was done across various centers from India in 5 Indian languages. And the study on the left is the study on ACE3 in 7 Indian languages, and which showed a high sensitivity and specificity for diagnosis of MCI as well as dementia using ACE3. But if you look at MoCA for that matter, you see that there is a significant heterogeneity with regard to sensitivity and specificity between languages, as well as because of the fact that the population which are included are not necessarily education matched. And you can see that that can impact the sensitivity and specificity. But definitely, it does reflect a good utility of MoCA or ACE3 for that matter as a good screening instrument. You can use it as a good screening instrument. Although with regard to specificity, it may depend on the language as well as education status of the individual. This is how you translate the group-based results into an individual patient care level. And when we looked at actual utility of our ICMR neurocognitive toolbox, which actually used multiple tools in comparison to gold standard instruments such as ACE3 as well as Ray Auditory Verbal Learning Test, we developed a battery of tests which included at least 2 tests in memory as well as non-memory domains. And we found significant differences between MCI and controls, indicating that the ICMR comprehensive neurocognitive toolbox has a reasonably good sensitivity and specificity for diagnosis of MCI. And when we looked at the subtypes of MCI that it had the ability to diagnose, we did find that the vascular MCI, that is the MCI due to vascular etiology, so the post-stroke vascular MCI, definitely this had a better specificity as compared to MCI due to other causes. So when you are selecting tests in each domain, it is important to discuss as to whether you need to rely on one test in one particular domain, or you need to consider at least 2 tests in each domain to consider significant impairment. So how do you generate normative scores? So when you want to establish whether a subject has impairment in a neuropsychological domain, the test score which we would call for in that particular domain should be ideally mean minus 1.5 standard deviation for that particular age and education matched control subject. In comparison to that age and education matched control subject, the score should be less than mean minus 1.5 standard deviation. So now the challenge is, as you can see here, the study on the left shows, how do you derive the kinds of means and standard deviation by looking at normal elderly subjects. And then you try to compare that with a subject who has a cognitive impairment. Now, you had 2 definite criteria which are available. One is that you take one test in a domain and consider impairment as mean minus 1 standard deviation in that domain as sufficient to diagnose as objective impairment. On the other hand, that is the Peterson-Winbald criteria. On the other hand, you have another criteria called the Jack and Bondi criteria, which relies on impairment in at least 2 tests, where you have impairment in 2 tests, and the score should be less than mean minus 1 standard deviation. So the Peterson-Winbal criteria is mean minus 1.5 standard deviation. The Jack and Bondi criteria is mean minus 1 standard deviation. And you require impairment in at least 2 tests in that domain to consider it as impairment. So what was found is that irrespective of the study that you used, both the multi-domain as well as the single-domain amnestic non-MCI subtypes which had a risk of incident dementias could be detected. And only the stringent criteria which used impairment in at least 2 tests in one domain. So for example, if you take the memory domain, I require impairment in say ACE3 as well as Ray auditory verbal learning test. So 2 tests. So if I have a test score less than mean minus 1 standard deviation in both those tests, that has a higher significantly associated risk with incident dementia. On the other hand, you can also consider tests which are novel tests and which slightly challenge the subject more to detect the early impairments. So in this particular study, we used the face and the name paired associate learning test, as well as the famous faces recall test to demonstrate differences between AD, MCI, as well as MCI and normal controls and MCI due to AD. And we were able to demonstrate significant differences utilizing novel tests such as the face name paired associate learning test. On the other hand, you can use some other challenging tests which would rely on forced choice recognition or simple yes-no recognition. So recognition memory basically means is that you give a stimuli group a set of stimuli to an individual, and after a time delay, you ask them to do a free recall, and then you show them the actual pictures or the words, and then you ask them to recall from this to see if they are recognizing this or not. That is very useful to detect encoding versus retrieval deficits. So if a subject is able to recall these without creating any errors, it would mean that these would be simple retrieval deficits on cued recall. On the other hand, if the patient is making commission errors in terms of identifying words or figures which they have not been shown previously, then that would be actual encoding deficit. So more challenging tests are in fact more useful to diagnose the entity of MCIs which are at risk of conversion to dementias. And coming to the non-memory domains, you have tests which are available in domains such as executive functioning or visuospatial domain, which have shown significant impairments between the dysexecutive single domain subtype of MCI versus the amnestic single domain MCIs. And you can see that the significant differences are encountered in tests such as the modified trail making test, the Stroop test, the letter fluency task, as well as abstraction memory, abstraction recall in subjects who have dysexecutive MCI in comparison to amnestic MCI. But if you look at the profile of impairment in the amnestic subtype of MCI, which involves multiple domains on cognitive testing, you can see that the impairment is much more in the amnestic multi-domain subtype in comparison to the non-amnestic subtype. So this is where identifying the domains of impairment become much more relevant. That is, you identify impairment in non-memory domains, the risk of conversion to dementia in that subject, that is multi-domain MCI, would be at a higher risk of progression. Your neuropsychological tests can also be used to try and identify the etiology or try to subtype the etiology of MCI. So in this particular study, we used neuropsychological tests to distinguish between the vascular, the non-vascular MCI from cognitively normal healthy controls. And we were able to demonstrate significant differences, not only in the non-memory domains, but also in the memory domains. As you can see in this radar plot, you can see the impairment in the memory domains is also quite high in vascular MCI in comparison to other cause MCI and cognitively normal healthy controls. And the memory performance scores, both in terms of learning as well as delayed recall, have a high correlation with the burden of white matter disease in these subjects. So these were subjects with post-stroke cognitive impairment who gave consent for testing, who subsequently we followed up. Now, what are the actual predictors with regard to conversion in MCI? So in our cohort of 95 subjects who were followed up for a median period of at least 6 years, we were able to show that around 22% of them had a risk of progress, had developed dementia on last available follow-up. And what test do you use at baseline to predict this risk? What we found is that if you rely on the Ray auditory verbal test recognition memory, that is ability to recognize the stimuli which were presented, as well as the new learning ability on the WMS logical memory. That is when you give a story passage and ask them to recall the items in that particular story. That in combination with the presence of errors on an executive function task, that is Wisconsin card sorting test, presence of perseverative errors, a combination of these were found to significantly predict the risk of conversion over a period of 6 years. And that had a very good specificity of 98%. And this was despite after controlling for age as well as years of education. So you can see that the impairment in certain specific tests at baseline in MCI can predict the incipient risk of dementia in this cohort which you are recruiting. Coming to the etiological spectrum, as you can see, the focus will be on the degenerative causes, but not to forget vascular causes, the mild behavioral impairments, which are due to the psychiatric causes such as depression. Then you have this entity of FTD phenocopy, where the subjects might experience behavioral impairment, maybe abnormal or neuropsychological testing, but do not harbor FTD pathology and may be essentially normal on detailed testing subsequently. And they respond well to treatment of the behavioral disorder or the neuropsychiatric manifestation. And of course, systemic and structural causes. But if you take amnestic MCI due to in a single domain, the most likely etiology is Alzheimer's. Multi-domain, it is again more likely to be Alzheimer's. On the other hand, if you have non-amnestic MCI and single domain impairment found in, say, attention and executive testing or in your behavioral, then you may be, or in your language, you are more likely to be encountering FTD with the aphasic subtypes in comparison to other etiologies, but not to forget the so-called subcortical dementias like the Parkinson's plus dementias, the PSPs, the PDDs, as well as certain degenerative ataxias, where in accompaniment with your mild cognitive impairment, you will see the so-called plus features, that is motor impairments, extrapyramidal impairments, ataxia, seizures, myoclonus, whatnot. And these can present to you in the early stage. And within the non-amnestic MCI, again, you have a whole challenging set of entities which include Alzheimer's disease, Lewy body dementias, and the FTDs, which should be considered. Do you have criteria to help you with this etiology-specific diagnosis? Yes. In vascular cognitive impairment, you have definite criteria which are defined, which is based upon understanding whether this has a temporal relationship to the presence of strokes and whether there is a stepwise cognitive decline. Similarly, in Lewy body disease, to identify prodromal Lewy body disease in subjects who present to you with, say, delirium and later on turned out to be cognitively normal, you try to identify for features of spontaneous Parkinsonism, recurrent visual hallucinations, fluctuating cognitions, REM behavior disorders, etc. But you also need to rely on an additional biomarker to support your diagnosis, which may be in the form of your neuroimaging or PET scans or SPECT or PET imaging, for example, the TRODAT. And then you have polysomnographic demonstration of REM behavior disorders and MIBG scintillographies. And this has been shown to be fairly useful at baseline to predict MCI, which is due to Lewy body pathology. On the other hand, you can also have criteria to define psychiatric onset Lewy body dementia as well as delirium onset Lewy body dementia. I'm not going into the details, but subjects who present to you with early late onset neuropsychiatric manifestations beyond the age of 50 years or present to you with the first episode of delirium subsequently recur, and then which subsequently recurs each time the patient develops an infection, you should have a low threshold to suspect the entity of Lewy body dementia. Now, how useful do you, in the modern era, can you actually rely on biomarkers to predict? We know that the biomarkers are known to, the presence of biomarker abnormalities are known to predate the presence of neuropsychological impairments or cognitive decline. And this is gaining more and more predominance in the current era. But let us see how relevant it is on relying with regard to this ATN framework, that is markers of amyloid accumulation, tau accumulation, and neurodegeneration with regard to predicting the cognitive decline in subjects who may be either cognitively normal or who have developed MCI in future. So in this particular study, which was published in 2014, it found that, if you have raised p-tau levels in the CSF or in the serum based on the ability to perform the test in your lab, you can predict the person has a high risk of dementia, irrespective of whether the subject is cognitively normal at baseline or cognitively normal progresses on follow-up. And those who had a higher p-tau level were more likely to experience cognitive decline in future. But now let us try and apply this to other criteria which are available. So you have various work criteria such as the NIA criteria for Alzheimer's disease and the International Working Group criteria. And you can see the proportion of subjects with amnestic mild cognitive impairments in those who are biomarker negative and biomarker positive. And for example, if you take the NIA criteria, you see that the amnestic MCIs were 68% and the those who are biomarker positive were nearly 83%. So that is, they had a marker of amyloid positivity as well as neuronal injury. And you can see that the progression to Alzheimer's type dementia was only 4% in subjects who were biomarker negative versus 59% those who were biomarker positive. And those who converted to dementia, they converted over a period of 3 years in patients who were biomarker negative and 2 years in those who were biomarker positive. And some of them had progression to non-Alzheimer's subtype, indicating that you may have to rely in future on some of these biomarkers. But now, if you look at the heterogeneity of results in various studies which have been published over time with regard to the reliability of these biomarkers, you do realize that there is a lot of challenge which is involved in this particular process with regard to establishing the validity of these biomarkers, both in the CSF. Biomarkers. That is, you need to combine an amyloid biomarker, preferably the CSF, with a tau biomarker, again, preferably in the CSF, along with the neurodegeneration biomarker to have the best prediction accuracy with regard to AD diagnosis. So what can we do in a scenario where you don't have these biomarkers available in your country or in your region, as is evident in India currently? So we rely on the imaging biomarkers. And briefly, what we do when we establish imaging biomarkers is primarily look at the structural aspects, functional aspects, metabolic aspects, and to some extent, the connectomics is if you are a center which conducts research. And you can see that there are certain patterns which you can identify at baseline, relying on semi-quantitative scores such as the mesial temporal atrophy score and the global cortical atrophy or the posterior cortical atrophy scores, as shown in this particular study. You are reasonably able to define whether the MCI has typical AD features, as shown in the figure in the column 2. Limbic predominant, which is can also be due to something called a late pathology or due to Alzheimer's disease, where you see predominant limbic involvement, or the hippocampal sparing pattern, where you have a predominant posterior cortical involvement. But you can have subjects who may be rated as minimally normal, minimal atrophy. In these cases, you may have to rely on other multimodality approaches, as shown in this figure, where we relied on perfusion imaging to establish whether the patient had a typical pattern of a posterior cingulate or a precuneus hypoperfusion in subjects who may have pre-existing volume loss, in this particular case on the left, whereas the figure on the right shows you no significant volume loss, but the patient had MCI and was neuropsychologically found to have the features of MCI due to AD. We were able to demonstrate on ASL the presence of the arterial spin labeling perfusion imaging, presence of hypoperfusion in the posterior temporoparieto-occipital regions, to really demonstrate that this, with specific involvement of the posterior cingulate and the precuneus, to demonstrate that this may be due to MCI due to AD. So you can rely on PET imaging significantly. So this imaging actually compares the FDG PET as well as the amyloid PET. And this uses something which is called dual phase amyloid PET imaging, where the amyloid uptake of the PET biomarkers is considered to be important. And you can see in the early phase of injection of the amyloid PET molecule, this may demonstrate reduced uptake in the temporo-occipital regions, which is similar to that of the FDG PET, as shown in figure B. But if you look that in comparison to the late phase injection, you can see that the amyloid uptake is very diffuse along the temporoparieto-occipital regions in this particular subject. The figures on the right primarily show you that, this may be a structurally normal scan, but your FDG PET imaging as well will show you a definite pattern of hypometabolism involving the frontotemporal regions in somebody who has MCI due to, say, a frontotemporal dementia. And then you can rely on something called a quantified PET imaging, where you can actually demonstrate quantification of the posterior cingulate and precuneus hypometabolism patterns in order to demonstrate MCI at risk of AD. And in case of persons with MCI due to Lewy body dementia, relative sparing of the posterior cingulate and precuneus on FDG PET with a reduced uptake along the temporo-occipital regions, specifically with sparing of the cingulate, which is referred to as a cingulate island sign, can often be used to demonstrate whether this is due to MCI due to Lewy body dementia. In the early stages, it is obviously better to combine modalities. So in this case, we were able to combine structural volumetry with perfusion imaging on arterial spin labeling imaging to show that this had a relatively good sensitivity and specificity for distinguish between MCI and healthy controls in as well as AD and healthy controls. So if you combine a volumetric measure with a perfusion measure, you are able to demonstrate significant differences or try to identify MCI from healthy controls. Now I'll end with a few cases. So primarily, this is a 60-year-old housewife who was educated for only 3 years, and you can see that that is going to impact the neuropsychological test scores, but had episodic memory disturbance to the 2 years since last 2 years with inability to cook properly and forgetting to turn off gas, and there was a significant history of low mood with familial stressors, and you can see that the baseline cognitive scores as reflected on ACE in the baseline, that is 64. You can see that the recall scores are borderline 6 out of 10, 6 out of 15 on auditory verbal learning score with significant improvement on memory, indicating that primarily the patient, but you can see that the patient had improvement on RABLT recognition, but you can also see the presence of this commission errors. You can see a high number of intrusive errors. And primarily, the subject would repeatedly indicate that they have heard this word before, indicating that maybe there may be an encoding deficit at baseline, but the patient had a high anxiety and depression score at baseline. Look at the scores, that is, it was 18 and 13 at baseline. And you can see that the impairment in the other domains was not very significant, except the patient was found to be inattentive during the phase of testing. So the patient was initially treated for depression, and then subsequently you can see a demonstrable improvement in the scores, but definite improvements which persist in the memory domains. Out of 15 items, still able to recall only 7, as well as in the passage learning, as well as passage recall, you can see a gradual trend for improvement, although they are nowhere near normal, given the fact that a score of 30 was considered to be normal. But here again, you are constrained by the fact that you are dealing with a subject who is not very well educated, but has demonstrated a remarkable improvement in the scores on follow-up over a period of 3 years after treatment for depression. But what is worrying here? So now, if you look at the actual scores here over time, you can see that this on the trails, that is, she took 1 minute 10 seconds initially to complete the trail A, and then later on, she took time in terms of by the second year and third year, she would take anywhere between 9 minutes 48 seconds and 7 minutes 53 seconds to complete her trail A. So now, which means that you are dealing with a psychomotor slowing, which seems to be persisting despite treatment for depression. And gradually over time, although the patient had no extrapyramidal features, by the 5th year of follow-up, the patient went on to develop a Parkinson's disease. So which means that this was probably a depressive contribution to MCI, but at the same time, the patient had PD-MCI at baseline, which we were able to follow up and which we were able to understand only on longitudinal follow-up. If we had used any other biomarkers, are we validated or are we justified enough to use biomarkers at baseline is the question which you should try to answer. Contrast that to this subject who was a 70-year-old doctor who presented to us with the insistence that he had Alzheimer's disease dementia at baseline. So in the first visit itself, he said, "Doctor, I believe that I have already developed Alzheimer's disease dementia. I'm not able to recall anything." Just look at the scores. So you can see that on the ACE recall scores are impaired. The RAVLT delayed recall scores are impaired. Again, on recognition memory, although there is improvement, you look at the number of commission errors. These RAVLT intrusions basically means commission errors, where he's recording words which have not been presented to him before. And you can see that that reflects a definite encoding deficit. Although the ACE scores are not too bad, maybe somewhere just above the cutoff for MCI for that particular age and education status. And by the time, that is the 8th year of follow-up, he developed dementia. You can see the ACE scores have declined with significant decline in the memory scores, as well as impairment in other non-memory domains. And you can see here that even the verbal and visual memory scores were quite significantly impaired. So this subject had amnestic MCI due to Alzheimer's disease in itself at baseline. And you can see here that the CDR scores were progressively increasing. It was initially stable at 0.5 and then gradually jumped, and the patient actually demonstrated impairment. But what did the MRI show? You can see that the baseline MRI, the figure on the left, shows no significant volume loss, but over time, on qualitative inspection itself, you can appreciate the volume loss. But what happens to the actual brain volumes when you measure it? So what we use is that we use an MRI pattern of assessment of brain volumetry using statistical parametric mapping, and map certain regions of the brain and compare that to age and education matched normal control. So in this case, we compared that to a subject with 71 and 72 years. And you can see that there was significant baseline atrophy identified in regions such as the entorhinal cortex as well as hippocampus in comparison to say the fusiform gyrus. But there was also significant atrophy identified in regions such as the posterior cingulate and precuneus in comparison to the controls, indicating that the volumetric scans can be used and can be followed up to be, really predict the risk. So this is the last case of a 72-year-old dentist who had this difficulty to recognize the people he met. And he would say that I know the face, but cannot recall who they are, and I am unable to name them. You can see the test scores are not too bad. The ACE total is just above the cutoff. ACE registration recall scores are, but the visual memory is definitely impaired. Semantic battery is borderline. And the subject demonstrated impairment on a recognition memory test for faces. So this patient had an aperceptive prosopagnosia. So this is MCI with a very focal presentation. And as you can see, this is an MRI volumetric scan, where right is right and left is left. And you can see that this demonstrates clear atrophy in the regions such as the right fusiform as well as the right temporal neocortex in comparison to the left. So what should be your approach? So this is the approach. I have already covered this aspect, but primarily, when you have a neuropsychological impairment, you try to establish whether this is MCI single domain, multiple domain, or non-amnestic MCI single domain, multiple domain, and then go on to your biomarkers if you have the availability, or you focus on your neuroimaging and functional imaging such as PET or other techniques which you may develop if you're interested in the research domain. But if your neuropsychological assessment is normal, the question you ask is it mild behavioral impairment? So you try and assess what is the social profile of this particular person. Is the person having mood disorder? Does the person have inability, have amotivational behavior, loss of social cognition? And then you try to follow up the patient. If you have identified anxiety and depression or psychiatric illness, you treat it and follow up the patient subsequently in future. Do not let go of the patient. Somebody who has only subjective cognitive impairment, you suggest reassurance and follow up annually, and your decision to perform further testing should be based upon what the person is reporting on follow up. And this is the latest profile which needs to be followed, whether you are dealing with MCI or early dementia. You try to establish which domains are involved, try to establish the severity of impairment and what is the functional impact. And what is recommended over time is that you need to establish whether the MCI is due to a specific etiology. Is it MCI due to Alzheimer's? Is it MCI due to an FTD, whether it's a tau pathology or whether it is a TDP-43 pathology? Is it MCI due to vascular? Is it MCI due to an alpha-synucleopathy? That is the etiology-specific approach you should be focusing on. So to conclude, you should always assess temporal changes in cognitive performances. You should propose follow-up in these patients to establish whether these subjects are stable or progressors. And you should, based on your neuropsychological test results, you should contextualize it. What I mean is you try to correlate that with the etiology and focus your work upon the etiology of MCI. Never forget that. And try to conduct more biomarker-driven studies. We are all constrained in India by costs. We rely heavily on neuroimaging. All my colleagues would agree with me. We rely more heavily on neuroimaging, whether it is MRI or PET imaging, but we should try to develop cost-effective biomarker strategies in our population. And then only we will be in a position to try to establish whether this is MCI due to a specific dementia pathology or whether this is a non-Alzheimer's disease cognitive impairment. And then we can give a prognostic trajectory to these subjects and try to support them as best as we can during their period of elderly life. Thank you so much. And over to the organizers.
Thank you very much, Dr. Menon. It was an excellent lecture, and I hope the audience have learned a lot about the MCI and the subjects, how to approach the persons who are coming to the clinic with the subjective memory complaint, how to make a diagnosis of MCI and how to prognosticate them, how to follow them, and how to predict the likelihood of getting conversion to the dementia in future. And of course, we do not have any disease-modifying therapy at the moment, but this is what we need to do in our clinical practice day to day. So now I would like our audience to have if there is any question, you can ask in the question answer chat box. Before opening to the audience, may I have one question to Dr. Menon? That the CDR is a commonly used tool to classify the severity of cognitive impairment. But do you feel that CDR is more biased towards Alzheimer's disease? If the person is not having a memory problem or amnestic type of MCI, CDR may be failing to assess the severity of the cognitive impairment. What is
Quite
your
true. Yes, sir, quite true. I did mention that, one of the aspects which are genuinely missing in CDR is with regard to the actual occupational functioning as well as the social functioning of the subject. It tries to identify it only in the later, once the actual impairments start. It doesn't try to look at it in the early stages. Definitely, one of the ways that, intervention studies have tried to go around with that is by focusing on the sum of boxes. That is the number of items which are ticked in those boxes to try to quantify the extent of impairment. But definitely, they have also tried to include another measure like the instrumental activities of daily living. Now, one of the problems with instrumental activities of daily living is that it relies mostly on the activities of which are simple to perform. It doesn't rely on the really complex activities. So in somebody who is of a higher education or an employment status, if they are experiencing impairments, they are not very well captured in such a IADL scale. So definitely, we need to be more pragmatic. But I think one of the ways to look around that, to get around that, is by focusing on what the individual wants or what the impairment the individual has. And without actually, the CDR and everything is good at a objective level when you want to look at the impact of your intervention. But at the impact of your intervention, like whether you're giving a medical intervention or a cognitive intervention, like cognitive retraining may be offered to some of them, and you want to look at the impact of that, you rely on CDR and IADL and for publication purposes or research purposes for that matter. But at an individual level, I wouldn't constrain myself to the CDR and IADL alone to decide. I would rely definitely a lot more on the neuropsychological test performances. If I'm sure the patient has been cooperative for the testing, and there is no confound such as depression, and if I have ruled out any other treatable etiology.
Thank you.
Thank you very much, Ram, sir, for that brilliant presentation. Just to add, I think what they have done for add behavior, they have used FTLD CDR and they've included all the behavior components in that. So maybe that can help us in including other domains as well if they're not covered up.
Yeah, the behavioral domains are definitely. I did not go into too much details on mild behavioral impairment, but there are now scales which assess impairment at the behavioral level as well, whether it is motivational behavior, social interaction, empathy, all these aspects are brought together. I have not gone into too much details on that, but in somebody who has a neuropsychiatric presentation, definitely it can be used.
So there are several questions in the chat box. If I can read out some of them. As Dr. Ashok Sirsa, he wrote that how important is teaching to give you a clue that a person with MCI may be going into Alzheimer's disease. So this is not a intuition, it requires a thorough assessment. I think Dr. Menon has already highlighted that.
Yeah, so baseline scores, you definitely need to rely on your baseline scores, as I mentioned earlier. Primarily, if a person has impairment in both memory as well as in non-memory domain at baseline, that is multi-domain MCI, the person is at risk, which may require follow-up. But as I said, rule out other etiologies before you label. And use one biomarker which you have, that is neuroimaging, to really prognosticate.
Another person, Dr. Aruna Sengupta, has written that at what stage of cognitive impairment is the use of biomarker for diagnosis justified? Is it only at the MCI stage or beyond that?
Yes, studies have one of the ways you can answer this is by looking at is the proportion of cognitively normal subjects who are biomarker positive, as well as subjects with memory complaints alone who are cognitive testing wise normal, who are biomarker positive, and then follow them up. Unfortunately, now with regard to the cognitively normal biomarker positive, that is somebody who has a marker of amyloid accumulation, it has been shown that 20 to 30% of them may not convert to dementia over a period of 8 to 10 years of follow-up. So 20 to 30% can be cognitively normal. So are you justified in, proposing it at baseline and, creating a heightened sense of anxiety in them to the extent that they might take certain drastic decisions is one ethical question which we have to answer. Unfortunately, we haven't, reached the level of validation of biomarkers. Whether you're taking, at least in India, we have not reached the level of validation of plasma biomarkers. CSF biomarkers, to a large extent, there are now kits which are available, which I understand many centers have started using, based on cutoffs which are available by the marketing company, that is Roche Diagnostics has given a set of cutoffs. We don't know whether those cutoffs are valid in our population, so we are not certain whether we can use that. Now, somebody who has subjective memory complaints with that incipient risk of dementia, which I had shown you, with our current understanding of biomarkers, again, if neuropsychological testing is normal, we don't recommend doing these biomarkers. At best, whether you want to rely on neuroimaging, there is no evidence to support the same. And it is still suggested that you longitudinally follow somebody with a subjective memory complaint who is objectively normal on testing longitudinally to answer this question.
Kirtana from Nimans, C. How accurately is it possible to differentiate cognitive impairment and normal aging in an elderly person above 70 years of age due to obvious age factor? And how can we strongly identify MCI in this population?
Yeah, so I have mentioned the sensitivity and the specificity estimates. Now, if you are looking at screening a particular population, you require a higher sensitivity. So you can use your screening instruments. With regard to specificity of the diagnosis, now whether this is MCI due to a particular etiology, it depends on in-depth analysis of the tools. Again, within the ACE or the MoCA subsets, you can rely on certain components to really identify whether this is MCI at risk. For example, in isolated memory domain affliction, if the person has performed less than, say, mean minus 1.5 standard deviation below, you know that the subject requires follow-up. Will you suggest an additional investigation? Yes. So it is possible that you can identify MCI in elderly subjects. Now, we wouldn't say that, 75 years, this would be a a less reliable test. Most of the studies which we have done, including our ICMR text toolbox in multiple languages, has shown that these can be employed to anybody who has crossed the age of 55 years. And these are fairly sensitive and specific for diagnosis.
And finally, another question from Dr. Chandrasekhar Rawat. How to treat MCI in Alzheimer's profile patient? Probably you have answered that, but
yeah, so I'm not gotten to the details of the molecular therapies which are being applied, but this is something which we are looking forward to. But there are a lot of questions which need to be answered as to how it impacts the brain radiologically, as well as what is the risk of hemorrhages as well as edema happening in consequence to these medical therapies. If you have identified MCI at risk and you feel that he's, say, neuroimaging negative for Alzheimer's disease, but is harboring risk factors such as hypertension, diabetes, and other things, you would definitely recommend lifestyle modification strategies in these subjects, because that has been shown to slow the risk. If the person is socially isolated, definitely that is another risk factor which has been shown. If they are, just after retirement, they are staying in an elderly age home, and there's no one to really interact with them. That has also known to, increase the tipping point. So definitely a lot of social adjustment may be required. On the other hand, there is no hard evidence to support the use of cognitive retraining. We have shown, in proof of principle that there is some effect of cognitive retraining in stabilizing them, but we are in the process of conducting a randomized controlled study with at least, physician blinding possible to try and identify whether it is efficacious enough to slow down the rate of cognitive decline in these subjects. But yeah, so medication, lifestyle interventions are what you can recommend. And medication is something which is there only in the horizon in terms of disease modification and not just the symptomatic treatment with donepezil or rivastigmine.
Yes, so I think the question of whether the terminology of mild cognitive impairment or mild neurocognitive disorder, as mentioned in DSM-5, these are interchangeable and depends upon which one you want to prefer. It is not a very big thing whether you are using the term MCI or a mild neurocognitive disorder.
Yes, yes.
So there are no more questions. So I thank Dr. Menon for this excellent lecture and giving our audience an insight about the MCI and its present scenario. I now hand over this to Dr. Fahim to take forward the next part of the session.
Thank you very much, Atanu sir and Ramshekhar sir. So we move on to the next case-based discussion, and it's my pleasure to introduce the faculty who will be moderating this, Dr. Sandeep S. Kumar. Dr. Sandeep has done his DM from Bangalore Institute. He's an enthusiastic neurologist, and he did a postdoc fellowship in cognitive neurosciences with us. His areas of interest are obviously cognitive disorders, headache, movement disorders, epilepsy, and he has publications to his name, and currently he's working as a consultant neurologist at the Yashoda Hospital, Hyderabad. And then the case will be presented by his resident, Dr. Shrikant Gadam. He's a senior resident in the Department of Neurology at the Yashoda Hospitals. So I hand over to Sandeep for the case-based discussion, and this session will be chaired by Atanu sir, Dr. Ramshekhar sir, and myself. So the title of this case presentation is Waiting at the Crossroads, Lost in the Crossword. So over to you, Sandeep and Gadam.
Thank you, sir. And good afternoon, Atanu sir and Menon sir. It's been pleasure to see you. And as I know, I've been student of both of you, Fahim sir and Atanu sir. So it's my pleasure to present a moderate case in front of you in this common platform, in this open platform. Our case is Waiting at Crossroad, Lost in Crosswords, presented by our resident Srikant Gadam, who is final year DNB resident here. He's very enthusiastic and he has a lot of interest in cognitive neuroscience. So over to Srikant, you just go on, start presenting.
Yes. Good morning, everyone. This is a 70-year-old female resident of Nizamabad, Telangana district. She's a graduate in English and she has done her psychology also. The informant is husband and the son, and the information is reliable. So coming to the chief complaints, she presented to the hospital with complaints of forgetfulness since 1.5 years, and difficulty in naming since 1 year, and behavioral abnormalities since 1 year. Before going to the history of presenting illness, I just would like to tell her daily routine. She's a retired headmistress. She was an English lecturer. She used to get up early in the morning, 6 a.m. She used to go for a walk about 2 kilometers, and she used to come back, read newspaper, both Telugu and English, and she used to do her routine activities on her own. She used to go for grocery shopping, and she had interest in watching Telugu movies as well as the news. She was a little reserved personnel, but she used to call her relatives and call them frequently on phone. Coming to the history of presenting illness, she was apparently asymptomatic 1.5 years back. To start with, the husband noticed that she has forgetfulness in the form that she's misplacing things, she's forgetting things where she has kept, and she's often forgetting to switch off lights and fans whenever she's coming out of the rooms, and she has difficulty with the forgetting recent conversations, and at times she will forget what she had for breakfast, lunch, and dinner also. And over the last 1 year, she has difficulty in naming objects. Like she used to describe the name of the object instead of she used to describe the object instead of naming them. And she used to frequently use the terms like this and that during the conversation instead of naming the objects as such. And she also had difficulty retrieving the names of persons, place, and things. And over the last 1 year, she has difficulty in writing also. Over the last this has writing difficulty has been progressing, that since last 6 months she's not able to do her sign also, and her check has been bounced most of the times, and she has a difficulty in reading newspaper for the last 6 months. And over the last 1 year, the husband noticed that she had behavioral abnormalities also, in the form that she was over friendly with the strangers, and she had excessive talking with strangers, and she had inappropriate laughter during the conversation. So otherwise, there is no history of asking same thing repeatedly. There is no history of hoarding, like collecting objects. There is no history of any obsessive compulsive disorder. No history of any craving for foods. No history of stereotypical movements. There is no history of apathy or loss of empathy. There is no history of suggestion of any REM sleep behavioral disorder. No history of any visual hallucinations or delusions. No history of any losing wear, bumping into objects, and there is no history of decreased self hygiene. There's no history of difficulty in dressing. There's no history of any difficulty in holding objects. There's no history of any slowing in walking or any other extrapyramidal symptoms. There's no history suggestive of any headache, vomiting, seizures, or any myoclonic jerks. There's no history of suggestive of any high-risk sexual behavior. No history of any urinary issues like urgency, voiding at public places and all. And there's no history suggestive of any systemic symptoms like fever, rash, joint pains. Coming to past history, she doesn't have any comorbidities. There's no history of diabetes, hypertension, hypothyroid, or any psychiatric illness in the past. Personal history, she takes a mixed diet, sleep is normal, there is no REM sleep behavior disorder, bowel, bladder, neck regular, and there are no addictions. Family history, there is no history in the family. Family members just have got any forgetfulness, psychiatric disorders, any motor neuron disease, Parkinson's disease in the family members. So to summarize, she's a 70-year-old female, retired headmistress, graduate, bilingual, presented with complaints of forgetfulness in the form of misplacing objects, forgetting recent conversations, difficulty retrieving names of persons, places, and things, and tends to describe the object instead of naming it. And there is a frequent use of words like this and that during the conversation, and had subtle behavioral issues like excessive talking and over friendliness with strangers, and without any significant motor, sensory, cerebellar, and cranial nerve involvement. So
Continue.
after the history and history of presenting illness, the domains involved would be, as she had forgetfulness in the form of misplacing objects and slips in her daily activity, and forgetting recent conversations and all. So there are two possibilities. It could be either an impaired attention, or it could be episodic memory loss. So attention, I would like to localize it to dorsolateral prefrontal cortex, and episodic memory, I would like to localize it to medial temporal lobe. And she had significant language deficit, that she had difficulty in naming objects, and she had difficulty word finding difficulty. So I would like to localize it to dominant hemisphere. And the other thing I told you, she had behavioral disturbances, like in the form of over friendliness, excessive talking with strangers and all. So I would like to localize it to orbitofrontal cortex.
Srikanth, I want the chairperson to comment after the history and summary and the domains, if they have anything to add. Atanu sir or Fahim sir, Menon sir.
Yes, very good presentation, Dr. Srikanth. And also seeing Dr. Vassini is there with our along with us. So I would also invite him to participate in this discussion. the problem in this 70 years old
Yes, sir.
educated lady was that she started with memory problem, forgetfulness.
Yes.
And although it primarily appears to be inattention, but also she had a very characteristic recent episodic memory loss,
Yes.
like forgetting the events in the morning or day before yesterday. So it is not only the attentional network, it is also probably the medial temporal or hippocampus that was primarily affected at the very beginning. But soon she also developed the language problem, particularly the anomia,
Naming the
having difficulty in naming the persons and objects properly. So, and also she developed subsequently other language problem as well, like reading and writing problem. So, so it is more of a language dysfunction, and of course the localization is the perisylvian cortex in the dominant hemisphere. And then she went on to develop some behavioral problem, particularly I don't know the characteristics of the speech, because in patients who are having aphasia, they might have very fluent speech, and they can have garrulous speech. So that can be described as the disinhibition and talking too much. But she also has some behavioral problem, like those who are not known to her, she becomes friendly to them. So the domains which are primarily involved are the attention and of course the episodic memory, then the language and some amount of behavior. The major domains which are not involved from the history are the visuospatial and visuoperceptual ability, the navigational ability, and the praxis part. So, but still, as it has started with the very early memory problem, pathologically the degeneration probably started in the hippocampus area, and it has not in a typical Alzheimer's patient, as it spreads from that area to the parietal cortex, it has probably not involved that. But we will come to know once you show us the test results and the investigations. So primarily the disease probably looks like an elderly person with an Alzheimer's pathology, but let's see whether the language was the major domain involved in this patient. We'll come to know after your test results.
Thank you, sir. Srikanth, continue.
Now, I request Dr. Menon and also Dr. Pine to put their comments.
Dr. Menon?
Yeah, very well summarized, sir. And thank you, Srikanth, it was a very good presentation. As I agree with sir on all the points, and the only aspect is obviously with regard to testing. It's obvious that the patient has an impairment in the activities of daily living. So this is early dementia, more likely to be of a neurodegenerative subtype, but your other etiologies are definitely plausible. There are obviously no other plus features. And with regard to the language aspect, I personally felt that this could either be a logopenic presentation of Alzheimer's disease because of the substitutions with this and that, which you were mentioning. But definitely, if there is a significant component of anomia, that has to be corroborated on your testing.
Thank you, Menon, sir. Fahim, sir, you want to add anything?
No, I think I completely agree with Atanu sir and Ramshekhar sir. Beautifully, they highlighted and summarized this case. Just to add, I think maybe as Ramshekhar sir said, I would also consider maybe a primary progressive aphasia. Well, I think it will determine whether on language assessment which type of aphasia it is. It could be anything, because I think she's using words like this and that. It could be any of the aphasias, maybe logopenic or maybe a semantic variant. But I think time will tell and your assessment. But on the other hand, she also has behavioral issues. So whether they are actually due to a full FTD spectrum disorder or a language variant itself, I think maybe once you assess and tell us the other examination, we'll come to know what it is. But I would, yeah, keep my fingers on FTD spectrum disorder, which would include behavior and language. So yeah.
Okay, Srikanth, continue. Srikanth?
Yeah, slides. Yeah, after the history of presenting illness and domains involved, I would like to the possibilities would be, as she had an insidious onset and gradually progressing disease without any systemic features, I would consider degenerative disease as the first possibility. However, the other secondary causes like slow growing space occupying lesion or a tumor should always be kept in mind. And the other possibilities would be a chronic subdural hematoma, and nutritional and metabolic causes should also be considered, and inflammatory and infectious causes should be also be kept in mind. Infectious causes, herpes simplex virus encephalitis can also present with such kind of picture. So these possibilities also be should be kept in mind. Coming to the examination, general physical examination, she was conscious and coherent throughout the examination. Her vitals were normal. She was a right-handed person, but she had inappropriate laughter while we were testing her. So coming to the cognitive assessment, attention A score. As you can see here, almost all the domains are involved: attention, memory, fluency, language, visual, spatial. The total score is around 47 on 100. I'll be telling in detail the cognitive assessment in the coming slides. Next. Coming to the orientation and attention, her orientation to time and place was impaired, and the forward digit span was 5, the backward digit span was 3, and the serial subtraction was only 1 on 5. So the attention is impaired. Next. So coming to the language domain, if you can see the spontaneous speech, the spontaneous speech was fluent, grammatical, syntactically normal, with the uh, frequent use of substitutions and circumlocutions, the frequent use of substitutions like this and that during her conversation. And coming to the naming was significantly impaired with familiarity effect. That is, she was able to name the familiar things like watch and pen, but she was not able to tell the unfamiliar words like an anchor, crocodile, and all. And she used a lot of superordinate errors during her speech, which I'll show in the coming videos. I have got her videos of the spontaneous speech. Repetition was normal. Comprehension, the single word comprehension was impaired. And reading, she was not able to read irregular words. That is, she had surface dyslexia. This also I've got the video in the coming slides. I'll show you. And the writing was impaired, and writing on dictation was also impaired. Next slide. So this is the video of a spontaneous. Actually, she's talking in Telugu. Actually, we asked her, how did she come to the hospital?
ఇద్దరం మేము వచ్చినాం, ఏదో తల్లి కొందరితో మాట్లాడాం, అన్ని పేర్లు ఉన్నాయి కానీ మేము చూడడానికి పోయింది.
What she is trying to tell is, she got into some vehicle. She was not able to name. Actually, she came in the train from Nizamabad to Hyderabad. She got in. She was trying to tell the name, but she's just told, "I got into some vehicle that sounded like dur 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 dur." She was not able to name exactly the train. She was not able to train that.
ఈ రోజు ఉదయం ఏం తిన్నారు మీరు?
వంకాయ.
But otherwise, her speech was fluent, grammatical, and syntactically normal.
తిన్న తర్వాత
ఇంకా
మీరు హాస్పిటల్ వచ్చారు కదా, ఇక్కడికి వచ్చారు కదా, హాస్పిటల్కి వచ్చారు కదా, ఇక్కడికి మీరు హాస్పిటల్ వచ్చారు కదా, ఎలాగొచ్చారు హాస్పిటల్కి?
Yeah, this is the writing. As you can see here, she was able to write the dog properly, but she was not able to write irregular words like knife. When I asked her to write, she just wrote NIG, and she was not able to write. And she was, though she's being an English lecturer and a professor in psychology, she was not able to write the spelling of water, and also she was not able to write Tuesday. When we asked to write the Tuesday, also she was not able to write. So writing on dictation was also impaired, significantly impaired. Next. So this is a video
పిట్టల ఏంటి ఇది
showing. I asked her what is it.
ఇది
ఏదైనా
ఇది పిట్టల ఈగల్ ఎద్దు గద్దన పిట్ట.
When I asked her what is it, it was an eagle.
గద్దనాన్ని గద్ద ఏగిట్లుండదు గద్ద అనుకోవచ్చు.
అనుకోవచ్చు. ఇది
She was just telling it is a bird. She was not able to name it as eagle. She was just telling bird. So she has superordinate errors. And this is also, when I asked her, she just told it is a fruit, but she was not able to tell the name of the fruit.
పండ
కమ్మ కమలకు ఉన్న పండు ఇవి.
కమ్మన్న పండు. ఓకే. ఇది
అది ఏది ఇట్లా కొట్టుకుంటే పాడు.
కొట్టుకోండి. ఏంటి ఇది?
దానికి అది
అది ఇది జీతో స్టార్ట్ అవుతుంది. జీ గీ గీ ఏంటి?
గుడిలో వాడేందుకు అది కొట్టినట్టు
గీ. ఓకే. ఇది 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 ఇది
ఇది అదే అడవిలో తిరుగుతుంది అది.
అడుగుతుంది. ఏంటి పేరు?
She was just trying to tell it will be present in the forest, it will be on the trees and all, but she was not able to tell the exact name of the animal.
అడవిలో ఉంటది.
చెట్లు ఉంటది.
పెరుగుతుంది. కోతి.
కోతి. ఇది
అది ఇది పిట్ట అంటే కాకి కాదు మరి ఇది.
She was also telling just it is a bird, not able to name it. So she has superordinate errors.
పక్షివా పిట్ట ఇది?
పక్షి పక్షి కాదు కానీ పిట్టది.
ఇది ఇది ఏంటి?
ఇది ఏంటి? ఊరు వస్తే పెట్టి.
ఇది ఏంటి తెలుసా? ఇది పండు ఒకటి. పండు ఇది. ఈ పండు పేరు తెలుసా? ఇది
ఇది వస్తాయా?
పండు. ఇది ఒక పండు.
ఆ పండు ఏమైంది?
పైన్ చెప్తారు. అనాస్ చెప్తారు. ఏంటి ఇది? అనాస్ అండ్ అనాస్ సురది. అనాస్ తెలీదా?
After giving the clue, she was not able to tell the name of the.
ఏంటి?
పెన్నా.
ఓకే. ఇది
ఏంటి?
చెప్పండి.
ఇది ఏందో మరి.
ఇది ఒక ఇది
కూరగాయ.
పేరు.
కూరగాయ ఏం కూరగాయ అది?
ఇదా
చూడలేదా? ఇది బంగాల్ చెప్తారు. బంగాళదుంప. ఆలుగడ్డ. ఇది
ఇది మరి సీజన్ తెలియదు. ఇంకొకటి
ఇది ఇది
దాంట్లో
ఇది ఒక వస్తువు. ఇది చేస్తారు, టైట్ చేస్తారు. మీ ఫర్నిచర్ లూజ్ అయిపోతే స్క్రూ టైట్ చేస్తారు.
Screwdriver also.
ఇది
When we use, she is not able to.
సూదిగా లేదు కదా?
సూది.
సూది కాదు కదా?
మరి అదేంటి?
మీరు చెప్పండి. సూది కాదు. ఏంటి? స్క్రూ చెప్పాను కదా. స్క్రూ టైట్ చేస్తారు. స్క్రూ అన్న టైట్ చేస్తారు. ఏం చెప్తారు? తెలీదా?
అటువంటి అన్ని మేమే
యూజ్ చేస్తారు. ఇది ఇది
ఇది ఏదో మరి ఏదో ఇది
ఇది వేసుకుంటారు.
స్మరణ వేసుకొని పోతాడు కదా.
మీ అబ్బాయి వేసుకుంటారు.
ఇది ఇది
Can you explain what she is telling now?
Yeah, she's not able to name the tie also.
వేసుకొని పోతాడు కదా.
How we use it, but she's not able
టైయా
to.
ఏంటి? ఇది టైయా కోట్. ఇది
అంగి అది మంచిగా ఇట్లా మీరు వేసుకున్నారు.
ఇది 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 చెప్పండి.
ఇది అంగి
అంగి
మంచిగా
షర్ట్.
అంటే షర్ట్.
అంగి షర్ట్.
Can you explain what is Angi to the audience?
ఏంటి?
ఇది చాలా రోజులు ఇది చూడక
చాలా రోజులు కదా. ఇది ఒక నీళ్ళ పోతుంది కదా ఏంటిది నీళ్ళ పోతుంది
She was just telling it is an animal. She's
ఇంగ్లీష్
going
లో
to
టాతో
but she was not
స్టార్ట్
able to
చేస్తారు
tell the name.
తాతోనే వస్తుంది
తట్
తాబేలు అంటారు
తట్
Was she able to tell the use tool? Was she able to tell the use of the tool?
టాటా ఇదా
Uh,
టాటా ఇదా
తాబేలే అంటారు కాదంటే
ఇది
Dr. Sandeep, Dr. Menon is
yes, sir.
asking whether she was able to tell the use of the tool or the use
No,
of these
sir.
objects.
No, sir. She was not able to tell the use of tools. And Tuti means hammer in Telugu. So she, instead of telling screwdriver, she told us hammer. And the chisel, she told us pen. And the tie, she told us it is as a cloth, is a shirt. And shirt, she told us cloth. And when we asked her that bird, eagle and penguin, he told us as pitta. Pitta in Telugu is bird.
అవా
And everywhere she the common things like here, no, she was able to tell. And she was not able to tell the name of the fruit, ananas. So I was giving her the phonemic clue as well as the semantic clues. She was not able to tell even after the phonemic and semantic clue. For example, when I showed her the guitar,
ఏమంటారు
she showed the use, but guitar is not whole in that way. When I gave her a clue, G starts with G or guitar, she was also not able to catch hold of it.
ఉంటారు కానీ ఏమంటారు
The other important thing here is also that they should have seen these objects prior to the illness, because if you show them something very new, they may not know all this. I
Nice,
know you have done
sir.
it in that context, which is fine, just for the information of the audience.
And sir, as in the when in the spontaneous speech, I asked her how she came to the hospital. So she remember when she got into the bus or the vehicle, when she reached Hyderabad. She came from Nizamabad to Hyderabad, and she was able to tell the describe the event, but you can see she was not able to tell the name of the vehicle. Bandi in Telugu is generalized for vehicles.
Vehicles.
Any bandi. Bandi means it could be car, it could be bus, it could be train, it could be anything. So she used the term bandi, and while coming, for describing the vehicle, she told dur 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 dur. Dur 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 could be a bus, it could be also train. Sir, now the handwriting. Yes, sir. The reading part.
చదువుకుంటాను
So we asked her to read the irregular words. She was not able to read.
ఇది
So,
ఇది ఇది ఇది
అన్ని ఉన్నావు కానీ నువ్వు
అంటే
so she was not able to read this irregular words. So she has surface dyslexia.
I want to add one point, sir, here. She is a graduate in English and psychology, and she used to teach geography and English and Telugu in her home, in her school, and she was also a headmistress there. She can continue.
Next step.
నైట్ ఇది ఇది ఇది
She was not able to read. She did her psychology, but then she was not able to read the spelling of psychology.
నేనేమన్నా చెప్పను
And for colonel, she read it as colonel.
For simple words also, she was using letter by letter reading. Was she able to read the entire word together, like continent and peninsula and all that? Was she able
No,
to?
sir. So continent and peninsula, she was after reading the whole word, she said that there is nothing, there is no word existing in such.
No, so do we term that as isolated surface dyslexia? Is my question. That is the reason why I asked that question.
I think, sir, there is surface dyslexia is there, sir, because
Is there, but given the fact that the words also which involved actual invocation of syllables, she was unable to read them, and it was more of a letter by letter reading. I think it has gone beyond surface dyslexia also. It has pressed much posterior.
నేనేమన్నాడండి
You can continue.
So did you give her some words, Sandeep? Simple words as well? Was she able to
Yes, the
read those
spontaneous
words?
writing. Yes, the spontaneous writing when I said in the Srikanth said there. So when I asked her to write dog, she was able to write dog, DOG. When I asked her to write knife, so she wrote NIFE instead of write KNIFE. Water spelling she wrote WATR instead of write WATER. Tuesday she wrote instead of writing TEUSDADDA, she wrote TEW and DAY.
Sentence writing, was it? How was the grammatical?
This is the sentence writing, sir.
Writing. So we asked her to write about the Christmas. She wrote in Telugu, which I have translated in the English. She wrote that Christmas has Kritamata festival will be celebrated in 12th month. She mentioned 12th instead of December. And she just wrote, I ate rice, fruits, vegetables, biscuit, tea, milk, and dal. So here we can see two types of errors, sir. One thing is Kritamata, so it's a phonemic error. Instead of Christmas, she wrote Kritamata. And for the month of December, she wrote 12th. It could be some semantic error. Instead of using December, she wrote 12th month. Coming to the memory, her anterograde memory, name and address test she scored 3 out of 7 by third trial. Coming to recall and recognition, her recall was very poor, and recognition was a little bit okay. As you can see here in the pictures, the recall, the delayed recall was very poor, but the recognition was little better. And retrograde memory, she was unable to name 2 out of 4 famous people. And auditory verbal learning, there was no the new learning was impaired, significantly impaired. And coming to the fluency, fluency was impaired. She was able to name only 6 animals. The scale score was 3. And the P words, when we asked, she told only 3. The scale score was 3. So fluency was also impaired. Coming to the visual, spatial, and perceptual, clock drawing was impaired. She was able to draw the circle, but the numbers she has written outside the circle, and hands she was not able to make it properly. 10 past 11. So it was little impaired. And however, the intersecting infinity loops, she was able to do it. And 3D wire cube, it was little impaired, but she was able to make it. So there is little visual spatial abnormality here. And line bisection test was normal. There was no right-left disorientation. She had no finger agnosia, but face recognition was impaired. She was not able to tell some famous personalities like Mahatma Gandhi. When she told she never saw this face and all. As famous personality, she was not able to name. Coming to the trial A test, test was little impaired. She took more than 2 minutes for completing trial A, and trial B also it was impaired. As you can see in the end, initially she was able to make it, but in the end she made some errors. So both trial A and trial B are impaired. Next.
May I ask, why did you feel that these were visuospatial errors, not executive errors?
So clock drawings are executive errors, because was tested in the visual spatial one. So I've told visual spatial, but the errors of clock drawing looks like executive errors, because initially the planning was impaired. She put the numbers outside the circle, and also while putting that both the hands, instead of putting on 10:10, I asked her to keep time as 10 past 10. She kept at 10, and another and second, and she kept at 6 o'clock. So coming to practice, I just want to add here, Srikanth.
Yeah.
So when I asked okay, explain.
Coming to praxis testing, pantomiming transitive was abnormal. Here I want to tell that when we asked her to pantomime familiar objects like how do you brush and all, she was able to do it normally. But when I asked her to show how do you use a screwdriver or how do you nail a hammer, she was not able to do it. This could be because that because of the semantic memory impairment, she would not have had the knowledge of a screwdriver or a hammer. So I thought because of semantic memory impairment only, this pantomiming the transitive gestures would have been abnormal in this patient. And actual object, when we asked her, she was able to do it. And imitation of meaningful gestures was normal. She was able to do it. And imitation of meaningless gestures, limb kinetic, was all normal. Gesture knowledge and tool selection was again abnormal to unfamiliar things like a screwdriver and hammer, and she was not able to do it. But familiar objects she was able to do. It was normal. Coming to the
just to interrupt here, I don't think it would be easy here to comment on apraxia testing when her semantics are not
Yes,
good. At that point of time, I would prefer not to comment and not say anything is abnormal here, because apraxia definition itself says you need to have at least your semantics normal. If she's not able to understand, so I would prefer not to comment on apraxia testing. I don't know, maybe Ram sir can.
Yeah, tool selection, I agree with you. Tool selection, to call it a conceptual apraxia because of this deficit in tool selection would mandate that language testing be normal. So the fact that your language testing is abnormal and indicating gross semantic errors when she was trying to name objects also, it would indicate that thing is because of a semantic loss of semantic knowledge.
No, sir, I just kept the apraxia part only to show that semantic memory loss will have a effect on apraxia screening. So I just kept the slides there. To come to that point only, because I just wanted to mention, like, because she lacks the knowledge about screwdriver and hammer. That's why she was not able to do all this.
Yeah.
No, I think what Fahim was trying to say is whether
You shouldn't comment
on whether this is conceptual apraxia. Because you have an apraxia which can be conceptual. So, but that's provided the language testing is completely normal.
Completely normal.
Srikant.
Coming to the motor system examination, motor system nutrition was normal, tone was normal, and power was normal in both upper limbs and lower limbs. So there was no abnormal movements. Sensory system was intact, and cortical sensations were normal, and cranial nerves were also normal. Next.
Asmita.
Yeah. Coming to the deep tendon reflexes were normal. Plantars were bilateral flexors. Next.
Asmita.
The cerebellar signs were normal.
Asmita, can you go to the next slide?
Asmita, go to next slide.
Extrapyramidal system is normal, and her gait is also normal. So after the clinical history, clinical examination, the patient is found to have impaired attention and language disturbance in the form of semantic paraphasias and superordinate errors, and executive dysfunction and memory impairment.
Sir, I want Menon sir for his second comment.
Memory impairment, would you consider it more of a working memory impairment or a true, long-term memory, or what kind of memory do you think?
Working memory impairment.
Yeah, I think we need to specify that this is episodic working memory impairment. And at the same time, given the fact that when you were giving the actual memory tasks, that is the process of list learning and all, she was unable to register those items. So new learning itself is impaired. So impaired registration, which may have affected the process of encoding in itself.
Yes, sir. The memory impairment, I like it to keep as working memory impairment more. And that verbal learning test also, because of so much semantic errors, lack of semantic memory, you don't have registers, you don't have able to remember that words also. So that's why the delayed recall is completely zero. So memory impairment, I will keep it as a working memory or because of semantic paraphasias, which is interfering in the memory part. So I just want to okay, after clinical examination, what are the domains we found is abnormal, and the memory impairment most likely due to working memory or because of and because of semantic memory also. Fahim sir, Atanu sir, please, can you comment? Sir, can you comment anything more?
No, it was extensively tested. I think they have thoroughly tested the language function as well as other cognitive domains, and I congratulate both of you. As Dr. Menon was talking about, that language was not restricted to the loss of semantics only. There was extensive involvement of the other part as well. Like she was having difficulty in reading regular words as well, not only the surface dyslexia. So she has alexia and as well as agraphia, and which cannot be explained on the basis of only the either loss of semantics, semantic dementia itself. And there was some areas of other areas of involvement as well. Of course, there are fallacies because the patient is not very much attentive or having so much of language problems. So interpreting the results of the other test like praxis and of course the memory is difficult. But I think there is also some problem in the clock drawing. So she put numbers beyond outside the boundary of the circle. So there was some special problem as well. I think agree that there is an executive problem. That's why she was having has lost the concept of clock, but also has some problem in the spatial problem as well. So it is not restricted to the semantic. Yes, it apparently looks that she has profound loss in the understanding of the knowledge of the objects and everything. But she also has some other cognitive domains affected. Only the semantic loss and the behavioral, we would have make a diagnosis of semantic dementia, but there is some other areas as well affected in this patient. This is my opinion. But of course, it is difficult to make a diagnosis at one go because we have not seen the patient earlier and we have not we don't know how the patients will behave in the future. So for degenerative disease, it is often very difficult to make a diagnosis after seeing the patient once only. So, but I think in these patients there are complaint of the memory, there are complaint in the language problem as well as the executive function, and subtle deficit in the field of other domains as well. So it is probably more diffuse in nature, not a focal disease, in my opinion. But I think Fahim and Ramsekhar.
I completely agree with sir. I think this goes beyond semantics actually, because you also said he has prosopagnosia, right? Not able to recognize familiar faces. So I think that also needs to be taken into consideration. And as sir said, language abnormalities, behavior issues. So I think it goes beyond the left side of the brain, beyond the left side temporal. Maybe the right temporal is also involved. And because prosopagnosia mainly is right side fusiform gyrus, right? If at all she has. So I think we need to be sure whether did she actually have prosopagnosia. And then the other components like the dorsal stream, the ventral stream, I mean, that has to be maybe checked in detail. And again, it'll be challenging because she has semantic deficits, which are forthcoming. But I think we need to take into account other deficits as well, which Dr. Atanu sir said, in addition to face recognition issues. Dr. Ram sir, any other comments on?
Yeah, I understood from the language testing that the sentence repetition was essentially normal, including nouns. Did I interpret it correctly?
Yes,
Yes, sir. Yeah.
Not
Sentence
single word.
repetition. Sentence repetitions were normal, sir. When
Yeah.
I asked for the repetitions was completely spared, they're not involved, even the nouns. But when we asked about the single word comprehension, that was impaired. One more thing I want to add here is when when you gave that simple comprehensions like pick up the pen, pick up the paper, she was able to do it. Maybe those because of over familiarity, she knows what is pen, what is paper. She was able to do it.
Yeah. But her comprehension to even grammatically complex sentences would obviously have been impaired if single word repetition was impaired.
Yes,
but
impaired.
her sentence repetition in general being normal, I would not be very inclined to think of the logopedic subtype. I would be more pushed towards the semantic subtype of PPA, which has probably involved both the dominant temporal as well as the non-dominant temporal and fusiform regions. So I agree with your first impression that this is a semantic variant of primary progressive aphasia.
I want to add one point, sir, here. See, while clinical examining her, so suddenly, see, out of blue, she asked me about my some personal questions, like whether I'm married, whether I have children. So you should marry early. So I feel like this could be some disinhibition or over friendliness, because she used to have very reserved kind of personality as per the family members.
Yeah, so point is whether social cognition can be impaired with isolated temporal involvement. I mean, normally when we talk about impairment in social cognition, we talk about the orbitofrontal cortex and connections and all that. But definitely, if you look at the disparity between functioning in the non-dominant versus dominant temporal lobe, what has been shown is that, patients with non-dominant temporal dysfunction can be more prone for mania-like symptoms. They can express at times excessive jocularity. Bitemporal dysfunction, you are very much aware of Kluver-Bucy's phenotypes, where they can be extremely socially inappropriate. I think it is still in the domain of the temporal lobe. But as Atanu sir said, the subtle point with regard to visuospatial dysfunction, whether you want to consider that the process has extended further posteriorly. But your language testing is nowhere near logopedic subtype of PPA. It seems to be typically the semantic subtype of PPA. So I would restrict myself to the bitemporal dysfunction. And definitely this is bilateral left more than right temporal degeneration.
Yes, if it is semantic, then of course there is involvement of the bilateral temporal lobe because of the having prosopagnosia and of course this sort of behavioral abnormality.
So can I have a comment?
Yeah,
Yes.
please, Ashwin, please go ahead.
Yeah. Thank you for the nice presentation, Sandeep.
Thank you.
I'll cut short my comments. I think we are looking at a cross-sectional examination of this patient, where we are actually examining the patient at a point and looking at the cognitive examination of the patient. What I think the history should have been a little more elaborate for the temporal sequence of events. Did this patient actually start with what Ram sir said, working memory problem? And how did it start? And then did it start with a semantic variant PPA per se, and later on converted to semantic dementia? How was the word finding difficulty, or how was the involvement of the semantics? Were the semantics was that deficit restricted to language or other modalities also? I think if we could delineate this thing from the history, maybe we could have got more clues about the possible diagnosis and maybe pathology. What was the underlying pathology? This is semantic variant PPA, most likely converting, most likely a semantic dementia, rather not a semantic variant of PPA, also involving, as sir said, bilateral temporal lobes. And as we know, behavioral abnormalities can be there in the right-sided semantic variant or even the semantic dementia. But we could have elaborated that on the history rather than analyzing the examination as such.
Yeah, one of the problems with this, aphasic presentation as say MCI, in order to understand whether they can actually present as in the very early stage with just the isolated naming difficulty. Now, very often in the clinic, we encounter, patients who just say that they have difficulty in naming people or remembering names of people and all that. Very often, it's not very often that in the early stages they come to you, unless of course you have a patient education program in place or something like that. But it is very unlikely that they come to you with that I have this difficulty in identifying objects. I'm unable to name objects and all that. But yes, our challenge should be, as Ashwini rightly pointed out, in trying to decipher from the early piece of information that did it present as an anomic aphasia and then did it progress subsequently. I think that was pretty clear in the earlier part of his history also, although he did mention the forgetfulness and everything, but he did talk about using this and that. which he probably did not detail on in the interest of time. But I think that in itself, the substitution of a common noun with this and that should be an important pointer in itself, which I think Srikanth has rightly pointed out.
Agreed.
So I just want to add one point here, sir. So when the patient came to the OPD clinic, so the things he told me is he has forgetfulness, and he was forgetting things and forgetting names. And one more thing, what they said, he's keeping something somewhere and forgetting it. This is the only history I got it, sir. I'm audible,
Fine,
sir?
Sandeep. Maybe you can do the investigations. Yeah.
Yeah. Srikanth, continue, sir. Srikanth?
I need to the slides.
Asmita, can you share the screen, Asmita?
So the provisional diagnosis, the first provisional diagnosis was a semantic variant of primary progressive aphasia. The second would be semantic variant of primary progressive aphasia and FTD overlap syndrome, because she had behavioral abnormalities and mild executive dysfunction also. I would like to consider overlap as the second possible diagnosis. And the third one is Alzheimer's disease. Alzheimer's disease also can present with semantic memory impairment. But she should have other features like visuospatial abnormalities and executive dysfunction and all. So I would like to keep that as the third possibility. Coming to the investigations, complete hemogram was normal. Serum electrolytes, RBS, LFT was all normal. Thyroid profile was normal. We found that her vitamin B12 was little low, that is 159. The paraneoplastic panel was negative, ANA profile was negative, and anti-thyroid antibodies were negative. Next. So this is a MRI of the patient, T2. The first on the left hand side, you can see this coronal image, which is showing significant anterior temporal atrophy. And on the right side also, you can see there is a bilateral anterior temporal lobe atrophy, left more than right. Next. So these are T1 weighted images, which show there is bilateral anterior temporal lobe atrophy, left more than right. Both, and you can see there is this is the T2 flare sequence, which also shows that there is a bilateral anterior temporal lobe atrophy, left more than right, and there is medial temporal lobe involvement also, you can see here. So because of the involvement of the non-dominant
the nostrils, the other cuts, supratentorial cuts, that is the perisylvian and posterior head region, since we were discussing those issues. Do you have those images?
Actually,
those images is not in the slide, sir, but those parietal and those things are nearly abnormal, sir. So the sir, it's mute, sir.
And in the coronal cut for at the level of the hippocampus, because the bilateral temporal horns are dilated, also on the side.
Can you go to the imaging, Asmita? Previous slide. Coronal one. Previous.
Yeah, there I felt there was a early perisylvian atrophy also. That is why I asked for those cuts.
Yes. Yes, you can continue.
So primary progressive aphasias, they refer to neurodegenerative syndromes with predominant effects on the language domain. They can be of categorized into three, that is semantic variant, progressive non-fluent aphasia, and logophrenic variant of primary progressive aphasia. It was Arnold Quick who described the progressive disorder of language in the early 19th century. And in 1975, Elizabeth Warrington wrote about the selective impairment of semantic memory. And in 1989, Snowden et al. And Hodges et al. In 1992 described the first case of semantic dementia, and Grossman et al. In 1996 described the progressive form of progressive non-fluent form of primary progressive aphasia. So coming to the root criteria for classification of primary progressive aphasia given by Mesulem et al., the inclusion criteria include difficulty in language is the most prominent clinical feature, and this language deficit, they are the principal cause of impaired daily activity in the people, and aphasia should be the most prominent symptom at the initial onset and during the initial phases of the disease. Coming to the exclusion criteria, the patient should not have other non-degenerative medical conditions, and it should not be accounted for any psychiatric disorders, and the patient should not have any episodic memory loss and visuospatial impairments, and there should not be any behavioral issues. These are the exclusion criteria. Next.
Okay.
Two slides are missing there.
Okay. Thank you very much for a very good presentation of a very unusual case. And I thank both Dr. Srikanth and his mentor, Dr. Sandeep, for presenting a very good case. We all agree that it is a degenerative dementia, and of course, there is a major part which is affected in this patient is the semantic loss and the language part that started, and it is now probably has extended beyond the anterior temporal lobe of the left side to involve the right side as well. And there is a prominent some behavioral problem manifesting as increased friendliness with the unfamiliar persons. But as we all discussed, that there is affection not limited to the language area itself, it has gone beyond that. So these patients are classically, which we use to make the diagnosis using the criteria, maybe not fitting with the typical criteria of having only semantic loss and only having the language problem, but they also have, this patient also has behavioral problem as well as prosopagnosia. So this is the beauty of this patient. I request Ram and Fahim to comment on this.
Ram sir?
Yeah, I think Sir has summarized so beautifully. There's nothing more to add from my side. Just since my topic also involved reviewing aphasic presentations, I'll just make a mention that MCI presenting as aphasia is another entity which is under-recognized for two reasons. One is they may be going to the psychiatrist after the development of behavioral manifestations. The other aspect is we probably are not giving due importance to testing those patients who report naming difficulties overtly. What has been shown is that, if you try to subclassify this, there are some studies which have, I think that the largest study involved probably 26 or 27 patients with MCI who presented as aphasia. And you can understand the lack of studies which are there in published literature. So those have tried to classify this into the non-fluent subtype, logopenic subtype, as well as the semantic subtype. And the most common manifestation was the logopenic subtype, primarily because it is AD which is recognized in the prodromal stage, and most psychologists and neurologists are tuned towards recognizing AD. So, but within the logopenic subtype, some of them had not only AD pathology, but also Lewy body pathology. Within the non-fluent subtype, they had obviously the tau pathology. And within the semantic subtype, it was either the tau or the TDP43 pathology, which was identified. So that is the largest study which is available on aphasic presentation. Now, in this particular subject, whether we could have changed the trajectory by identifying this early, obviously in the current point in time, unlikely. Whether speech interventions in the early stage would have changed the trajectory, again, unlikely. But yes, whether it would help to stabilize to some extent the disease course is something which can be explored. So I think the audience should not just treat this as to why is this an exercise into subtyping when it ultimately does not translate into anything meaningful. These are going to be your cohorts for your intervention strategies in future. So definitely as neurologists or neuropsychologists, or for that matter, speech therapists or linguists, or even psychiatrists for that matter, we should pay attention to this aspect. Excessive jocularity at presentation, anybody more than 50 years, going to the psychiatrist, make sure that you go in for that kind of testing before you label the patient as a primary psychiatric condition. So I think all these aspects were brought out beautifully by the presenter, Dr. Srikanth, as well as his mentor. And thank you for this opportunity.
Yeah, it was a very nice case. I think I would say it's not a classical semantic dementia, as Atanu sir said. It's more of an atypical semantic dementia involving the right temporal lobe as well. So because nowadays, if you see the pathology of a classical semantic dementia is TDP-43 or maybe tau, but they have reported nowadays if the bitemporal involvement is there, semantic with atypical involvement of rights, it's a GGT. They call it globular glial tauopathy. That's a new entity which has come, and it has 3 types, and type 1 presents with this kind of a thing when we have bitemporal involvement. So I think that thing should be kept in mind. And as Ram sir said, I think intervention at a very early stage is very important, because we have a cohort of patients with classical semantic dementia here. I mean, I had seen them during my residency, and they keep on calling me now as well, because speech therapy helped them to some extent, if not in improving them completely, but at least stabilizing to some extent. And I mean, they're still stable. I mean, they haven't progressed. Obviously, some of them have, but majority of them are still going on. So I think speech therapy helps as other interventions. They do help at a very initial stage. So thank you very much for this wonderful case. And then, yeah. Over to Atanu, sir.
No, I fully agree with Dr. Ram and as well as you. And both of you have analyzed the patient very elegantly. And of course, this is an area Dr. Ram was talking about, that when the patients, elderly persons start talking much and making excess jocularity, they usually go to the psychiatrist, and the psychiatrist, the patient usually do not get a diagnostic leveling. We missed them. So very early detection of this type of patients is difficult for patients. They do not understand. Also, they do not find a good doctor because they do not go visit the neurologist at the hospital. I think we have reached a point of almost 2 hours of this webinar. So I thank all of you, especially Dr. Ram for this excellent lecture, and also Dr. Srikanth for presenting a very excellent case, well worked up, and his mentor, Dr. Sandeep. Sandeep has now become a senior consultant neurologist, and also, of course, he is now training other juniors to become a cognitive, to improve their interest in cognitive neurology, and we are very happy with that. And I also thank Dr. Rossini to be part of our team. And of course, I do not have anything to say about Dr. Fahim. He is the main person who organized everything for these webinars, and the audience who have participated in this program. And with your encouragement, we will continue to do these webinars every 2 months. And we will, of course, plan for other activities. In the next Sunday, we are going to have our business meeting, the Cognitive Neurology subsection of the Indian Academy of Neurology. We will discuss more about this, what other programs we can do. I also thank the digital team of the Indian Academy of Neurology, particularly Dr. Smita, and of course, the Indian Academy of Neurology, the president, the secretary, and everybody in the governing body, those who have allowed us to use this platform to organize these webinars. And of course, if I have made any mistake of mentioning anybody, please forgive us. And we conclude this session. We'll meet again after a certain period of time in another webinar. Thank you very much.
Thank you very much, everyone. Have a good
Thank
day.
you, sir.
Bye.
Yes, sir.